Yeah, please. They can read out the question, Satish. No problem.
Sir, I will read.
Yeah. Read out the doctor's name if at all it is there. If
Sir,
not
sir,
the
sir, sir.
question, at least.
So, sir, if sulfonylurea is used during ICBG, will it cause beta cell
ICBG.
exhaustion?
What is ICBG?
CBG,
Huh?
ICBG, ICBG, they have kept it.
CBG.
CBG. क्या? Casual blood glucose.
Intensive care.
Will it cause beta cell exhaustion as patient reluctant to take insulin? Can we tell them they will lose beta cell faster if sulfonylurea used during leukotoxicity? Something they kept like this.
Sir, you read it again, Satish.
Sir.
Yeah, from the beginning you start, okay. If sulfonylureas,
used during
yeah.
ICBG, will it cause beta cell exhaustion as patient reluctant to take insulin? Can we tell them they will lose beta cell faster if sulfonylurea used during leukotoxicity?
Acha, the question is, I'll put it in this way, okay. If the patient is running high blood sugar levels, the patient is using sulfonylureas and he is reluctant to use insulin, and his pancreatic beta cell function will be lost if he is not on insulins. And what about his glucotoxicity? Is that the question? I think, yeah, it is summarized, okay?
Yes, sir. Like
Yeah, okay. See, first thing, I've told you very, very clearly that forget about CBG or the fasting plasma glucose or the postprandial plasma glucose, whatever it may be. So, nowadays it is called the casual plasma glucose, not CBG, it is CPG. Casual plasma glucose is a term replaced for the random blood sugars. So, if the patient is running high blood sugars, there is no pointing in using sulfonylureas. It is something like whipping a tired horse. Already the pancreas is tired and you are still whipping it with this. The horse is being whipped with this sulfonylureas. So the glucotoxicity increases and he will reach a stage where it is called the secondary OAD failure, and the glucotoxicity increases and the lipotoxicity increases and the patient lands up in some complication. So it is not advisable. Even the patient is reluctant to use insulin. At least methodically I have told you, you cannot straight away go to a sulfonylurea. You have to try with metformin, then add this particular combination, or else you, in the beginning itself you can go for a combination of metformin and sulfonylurea, preferably the gliclazide and the glimepiride. Please try to avoid glibenclamide, especially over the age of 60, because it produces a lot of hypoglycemic events which are not reversible. The fatal outcomes are seen with the hypoglycemia induced by this glibenclamide. So you can use, if the patient is not able to afford to go for either gliclazide or glimepiride, you can at least go for the cheapest one, that is glipizide, but not the glibenclamide after the age of 60 at least, because these are the modern sulfonylureas, the gliclazide and the glipizide, the glimepiride. And along with metformin, if you use that and the patient is not to the target, you can go for either DPP4 inhibitor, or the best is the SGLT2 inhibitors. The patient is very reluctant to insulin, you can add the third agent. You said the patient is only on sulfonylurea. That is no way acceptable. You have to use multiple agents, because the mode of action is totally different. The sulfonylurea, they just squeeze out the existing insulin from the beta cell, and they lead to pancreatic beta cell exhaustion, leading to pancreatic bankruptcy. Whereas you can go for a sensitizer, start with a sensitizer like the biguanide group of drug metformin, which is a classical insulin sensitizer. Along with that, you can go for either the combination of the SGLT2 or the DPP4 inhibitors have come into vogue. The patient is so reluctant to insulin, you counsel him that glucotoxicity can be minimized only by usage of insulin. If it doesn't listen to you, you can at least go for a combination of the empagliflozin with linagliptin, or the combinations like the of late the vildagliptin has come down. The Novartis people have it is off patented. It is available at the 100 milligram of vildagliptin SR is available at 10 rupees, and you can add one dapagliflozin which is available at a very economical price. The Cystopic company has launched it at 6 rupees, that is 5 rupee 90 paisa, the 10 milligram. And even the blood sugars are not controlled with lifestyle modification and the therapeutic lifestyle changes. You just have to tell the patient, counsel the patient the importance of glucotoxicity and the importance of the landing up in complications like the heart attack, stroke, and all the microvascular or the macrovascular. And somehow you have to convince and counsel the patient towards insulin along with the existing OADs. See, OADs will never address the glucotoxicity, and the insulin is the only drug of choice that is going to take care of this the glucotoxicity. And insulin, what I said about the greatest advantages of this biphasic insulin aspart or the other designer insulins or the other analogs or the co-formulations is the reduced glycemic variability and the very less incidence of hypoglycemias are seen with this particular, and they are almost weight neutral, or they might not at least increase the weight, though they fail to reduce the weight, at least they are weight neutral. So keeping all these positive points, it all depends on, see, if you cannot counsel the patient, you better refer it to a qualified person and more experienced person, but don't spoil the patient, that's what. And the take home message is insulin is the only the one drug that takes care of glucotoxicity, that is to be used in hyperglycemia, that's all. No second thought in that. Sadish, next question please.
Sir, another doctor has questioned, sir, I have one case of 7 HbA1c, but urine sugar shows 2 plus. What is your advice? She is not on any allopathic medicine.
She is not on
metformin. Any allopathic medicine. Still I prescribe metformin 100 mg BD.
100 mg BD? No way. Metformin will be 500 mg BD or 1000 mg BD.
Maybe sir, they type like that.
Yeah, it is a typo error actually. Metformin is not available in the strength of 100. It is available in the 500. The plain or sustained release, or 1000 plain or sustained release. So the patient is running an A1C of 7. It is reasonably good. With the diet and exercise, I think the patient can cope with that. And I wouldn't advise the patient to be on any other drugs like alternative systems like homeopathy or Ayurveda, because I am a trained professional in the modern medicine only. I don't have any idea about that. I am almost an illiterate in that particular the other systems of medicine. So you can there is nothing wrong after going through all the parameters, not only the HbA1c, also this particular the fasting and the postprandial glucose and the lipid profile and the kidney function and the 12 lead electrocardiogram. And after assessing all these things, because just mere HbA1c will not give you every clue, because it doesn't say anything about two things. One is it doesn't say anything about the hypoglycemias. Second is it doesn't say anything about the hyperglycemic crisis. It only gives the mean plasma glucose, the estimated average blood glucose for the last preceding 3 months, that's all 90 days. So first thing is no idea about hypoglycemias, no idea about hyperglycemias, and no idea about the glycemic variability. These are the pitfalls of HbA1c. So you should look into the glycemic triad, the fasting and the post lunch, and the SMBG is very much required. That's what I keep on telling in every of my lectures. Like self monitoring of blood glucose, ask the patient to purchase a good blood glucose glucometer actually. Like you got Johnson and Johnson, the LifeScan, the Roche, the Abbott, and so many good companies are manufacturing. So they can as well purchase one, and they can monitor in the home itself. And once in a month you go to the doctor, you maintain a log so that your doctor will be able to recognize when the patient is dipping, when the patient is getting into hypoglycemia, whether it is nocturnal hypoglycemia or the daytime hypoglycemia, or if at all there are any excursions also. Especially the postprandial glucose excursions are very, very dangerous. In that case, you just have to add the alpha glucosidase inhibitor. Preferably, I prefer oglibose to acarbose because of the reduced GI intolerance actually. So in that case, you need to evaluate, and you can counsel the patient regarding the lifestyle modification and the therapeutic lifestyle changes, that is diet, exercise, so the reduction of the weight, cessation of smoking if applicable, cessation of alcohol if applicable, and after that ask the patient to stop all the bloody nonsense. You can put the patient on metformin 500 mg at the bedtime sustained release, or the twice a day 500 mg metformin. The patient requires it. So there is nothing wrong in putting the patient starting with the metformin, maintaining A1C. Yeah, the most important thing is not mere initiating. It is optimization. It is intensification of the treatment, and periodical monitoring is very much required because these are the chronic therapy segments where the patient has to be under supervision for his or her entire lifetime. I think that's clear, Satish.
Sir,
yeah, you can.
Garima has posted.
Dr. Garima, yes.
She's telling Dr. Mohan sir it's a nice presentation.
Oh, thank you, Dr. Garima. Okay. Pardon? Pardon, Satish, you are not audible. You are not audible, Satish. Dr. Pankaj Patwari.
Yes, sir.
Yeah, Dr. Pankaj Patwari. Yes, tell me.
In one Smith study, why they used a high dose of glimepiride 8 mg, metformin 2.55 grams, was it rational?
Pardon? In one mixed study?
One Smith study,
why
they used a so high dose of glimepiride 8 milligram and metformin 2500 gram, was it rational? He is asking.
No, absolutely. See, these studies are not done in India because the maximum cutoff of this particular metformin for Indian scenario is only 2 grams. That is in divided doses. 1 gram in the morning, 1 gram in the night. As far as the Western scenario and the other rest of the world is concerned, the maximum dose of metformin will be, they give 850 milligram in the United States of America, or in the other part, the European Union or the UK or the Australia. Because of their large body mass index and all, they use 850 milligram thrice a day. That becomes somewhere around some 2550 milligrams of metformin. So glimepiride can be used to the maximum dose of 8 milligram, but in divided doses. I prefer to stop glimepiride 2 milligram or in the morning, 2 milligram in the night, or max by max 3 milligram in the morning, 3 milligram in the night. And the maximal therapeutic dose of glimepiride, according to the evidence-based medicine and according to the literature, is 8 milligram. You can go until the 8 milligram, that is 4 milligram BD is rational. But this particular 2550 is not in the Indian scenario, must be in the this thing. It's a good question, but okay. You see, there is a therapeutic maximal dose for every drug. Like metformin, it is 2000 milligrams. For this particular glimepiride, it is 8 milligram divided dose. And it is gliclazide, it is 320 milligram in divided 2 doses. If it is the glibenclamide, it is 10 milligram twice a day. If it is glipizide, it is 10 milligram BD doses. That is maximum is 20 milligram. You cannot go beyond that. I don't advise you to go to the maximal dose as far as sulfonylureas are concerned, because they are not of any use. They are going to with the pancreas, they are going to squeeze the pancreatic beta cell, and they are going to take out the existing the insulin whatsoever is there in the little quantities in the pancreas, and eventually your pancreas will be bankrupt, and the patient has to be on insulin lifetime. So as far as other drugs, I would like to advise you to go for the maximal the limits, but not the sulfonylureas. I don't think it's rational even to go for 4 milligram twice a day also. I don't advise, because they are not going to, they act on the pancreas only. We should try to avoid the sulfonylureas, as the newer drugs have come, like of late the DPP4 inhibitors have come, the SGLT2 inhibitors have come, and to start with metformin is there, and if at all it is not contraindicated, low dose of pioglitazone is more physiological. If there is no volume overloaded state and all, you can go for that. Though there is no mortality benefit, you can go for alpha glucosidase inhibitors like acarbose or voglibose to keep the postprandial excursions in control. And you have got several drugs like, okay, the off late, though costly, the GLP-1 receptor agonists have come, like the injectable liraglutide, or the once a week liraglutide, or once daily semaglutide tablet has come, and of late this particular the once a week semaglutide injectable has come with established cardiovascular data as per the sustain and the pioneer studies. We have got beautiful evidence based medicine. So this 1 week, I don't think, Pankaj, it is a rational approach. Certainly not. I totally agree with you.
Sir, again by Dr. Pankaj Patwari, he is asking how is no insulin is better than lupicillin or epicillin as cost is issue.
Lupicillin.
He is telling how is no Nordisk insulin is better than either lupicillin or epicillin, OA Pharma, as the cost is the issue with the
Acha. Okay. It's a wonderful question. See, at the end of the day, what comes is it should match the international quality. See, any insulin you take, either it is from Lupin or from USV or from any other company, I don't mind. There are several insulins. Because I have never used, even Biocon has produced insulins. Biocon was purchased, insulin was purchased by Pfizer people to market around in 140 countries in the world, except 4 countries. The India, Brazil, and some 4 countries, Biocon had the rights. They have purchased this other this insulins from Biocon. The Pfizer has purchased the rights to market in 140 countries by paying a huge amount of 5,200 crores of Indian rupees. And afterwards, what happened? They have manufactured lakhs and crores of vials, and they have distributed, and then the post-marketing surveillance have shown that they are no way at par with the Novo Nordisk product. The human mixed-ad was the standard therapy, and there was no match in between the Biocon insulin and the Novo Nordisk insulin. So in that way, the bioavailability or this particular international standards of care, they are not going to match this particular. I don't say anything about your favorite brand. Lupin may be your favorite brand. You can write to your patients. If you want your patients to be safe, go for an international brand, go for an MNC. What is the difference? It is available at 158 rupees. I don't know the cost of Lupicillin because never ever in my life I had written anything other than the human mixtard, the human actrapid, the human insulatard. 90% of my patients are on these particular insulins only. Only 10% of my patients are either on Novomix or the Rhizodec or the Tresiba. See, majority of the patients are on that because it goes by quality. I am not endorsing Novo Nordisk just because I am a speaker for this. I am speaker for all the multinational companies. I don't mind the price, but I mind the quality actually because I don't have any experience with that because they have not stood the test of time at all. Because I have quoted the example of Biocon because they have dumped all the vials to Biocon people only. They just left the market. Pfizer totally left the market of insulin with that. So that speaks volumes about the quality of Novo Nordisk. Anything has to match with either the Novo Nordisk in the rest of the world. In the US, it should stand with this Eli Lilly brand because these are the two giants. The first one, the commercial preparation after banding bast, the Macleod and the Colip, they prepared this particular insulin way back in 1921. It was given to Leonard Thompson on January 11th only. So centenary celebrations were done very recently, January 11th. So 100 years, the first patient to receive insulin was a 14-year-old boy called Leonard Thompson. So he recovered well. He died of pneumonia at latter stage because there were no antibiotics at that particular time. So from then, the first commercial preparation came out by Eli Lilly, and the second commercial preparation, that is in 2022, Eli Lilly got this particular biphasic human insulin, and then this particular the Novo Nordisk in 23 got this biphasic premixed insulin, not human actually. Sorry, it is not human actually. Human was late, very late, like 93. It was genetically engineered rDNA insulin was prepared by this Novo Nordisk people. So it should match with the quality of the international brand. It doesn't mean that I am endorsing Novo Nordisk because I am given an opportunity, because I am a speaker for Novo Nordisk, I am a speaker for Novartis, I am a speaker for Boehringer. You take any MNC, I am a speaker for that. It doesn't mean that see, without using on my patients, I would never endorse. I totally endorse the products for which I am talking for because I have got vast experience of 3 decades, starting from the bovine insulins to the porcine insulins to the genetically engineered rDNA insulins to the co-formulations also. So with my vast, rich experience, clinical experience, I can tell you what is the quality one and what is not. Is that clear? You have to check the prices because there was a comment that they are priced high. The human mixtard is priced high. I don't know. I write human mixtard day and out. It is available at in my place. It is available at 158 rupees 50 paisa. And I don't know about what you mentioned, the Lupicillin or Osulin. I don't know how much the cost is. I just have to refer to this Google and have to ask the people. Do you have any idea how much Lupicillin? Hold on for a second, Satish. Hold on. Hold on for a second. Okay, see, the debate has come. It should be like, okay. See, it is Lupicillin M30 solution for injection. It is available at 157 rupees 84 paisa. The one I prescribe is available at 158 rupees 50 paisa. There is hardly some 70 paisa difference. My product is high by 70 paisa, but my product is a quality one and my patient is safe and I am also very safe. Is that very clear, Mr. Pankaj Patwari? You have anything? Please type again and type, okay?
He is continuously shooting questions, sir.
Yeah, let him. He's a DNB student of endocrinology. I know him. He's my student, okay, no problem.
He's asking what is the difference between human insulin and analog insulin?
Yeah, see, I have told you the difference between the human insulin and the analog insulin is all the time. I think he did not listen to my lecture at all. The insulin has got two chains. Alpha chain consisting of 21 amino acids and the beta chain consisting of 30 amino acids. And if you change one amino acid at particular one level, for example, this particular, you take this biphasic insulin aspart, you take insulin aspart, not anything. Insulin aspart at the level of B28, the proline is taken off and it is replaced by aspartic acid, making it more stable, more efficacious, more monomeric insulin. That is the difference between the difference between the human insulin and the designer insulins is you just have to wait for half an hour. If you give a biphasic human premixed insulin, you don't need to wait for that time. And second thing is, you don't have the hypoglycemias, especially the nocturnal hypoglycemias, very especially the serious nocturnal L3, level 3 hypoglycemias with this particular designer insulins or analog insulins. And there is significantly low weight gain when compared to the conventional human insulins. So these are all the greatest advantages. But I mind you once again, 90% of my prescriptions are because of the common man. I keep the common man in view. I have to justify that the purse of the patient. So I go with only the human biphasic premixed insulins only. That is especially the Novo insulins only I use. But these are the differences that's going to make, like you want to take a branded shirt, like you want to have a Raymond shirt or a Park Avenue shirt or a Louis Philippe, you have to shell down some 3,000 or 4,000. Whereas you want to have a normal shirt is always a shirt. But okay, the durability, the quality and the longevity, they all count in that particular this thing. So you want to have a quality one, you go for a quality one. You don't want to go for a quality one. Okay, Chalti ka naam gadi, there is a policy. Like they see it doesn't, I never mean to say that they are inferior to this particular the designer insulins. Biphasic human insulins are no way inferior to the analogs or the designers. But what I say is, the analogs or the designer insulins are much superior when compared to the conventional human insulins in much this thing. I have told you the reasons, the good glycemic control and the timing and the dose of flexibility and the incidence of hypoglycemia and the weight gain. These are all the greatest advantages with which you don't have with the conventional human insulins. Pankaj. Yeah, I'm glad that Pankaj is there. He is making this session very live so that all the doctors will be able to understand the fundamentals of this thing.
And sir is asking,
yeah,
can I use the sulfonylurea, metformin, pioglitazone or any other triple drug combination if fasting plasma blood glucose levels is at 250 and postprandial at 320 in a drug naive patient, as many times patient is reluctant to take insulin?
Yeah, it's a wonderful and very practical question, Pankaj. But I tell you one thing. You have checked fasting and post lunch. I would request you to check the A1C. You should have the A1C level in a newly detected type 2 diabetes mellitus patient or the drug naive patient. Along with the lifestyle modification, nobody is interested in insulin. See, if I were to be a patient, I would also say, no doctor, I will never take insulin. But when it is the HbA1c that determines whether the patient requires insulin in the initial period or not. That is called the hypothesis called early initiation of insulin. So I think way back in 90s we had this concept from Novo Nordisk only, because that is the only way to preserve the pancreatic beta cell functioning mass. Either the mass and the volume and the both are preserved with this early initiation of insulin. Thereby you are giving rest to the pancreas. You are not utilizing the existing the leftover functioning beta cells. You are not whipping the tired horse. So you are giving rest to the tired horse, so that you can definitely go for a triple drug combination, whatever be the blood sugars, but provided you have an HbA1c done. Because if the HbA1c says, that's what I have told you, the pitfalls of HbA1c is, it gives you a mean plasma glucose, an estimated average glucose for the preceding 90 days. It doesn't give you any clue about hypoglycemia. It doesn't give you any clue about hyperglycemia. It doesn't give you any clue about the glycemic variability, which is very, very important. So, keeping this in view, you have to check the A1C, and if the A1C is less than 9%, you can go ahead with a triple drug at a time. You can, Now the funda is hit early, hit hard is the treatment of diabetes. Hit early and hit hard, that's it. You can go ahead with the triple drug combination straight away, like metformin, sulfonylurea and pioglitazone combination, if there is no contraindication for pioglitazone, because it may precipitate a sudden heart failure, acute heart failure, whatever it may be. Like, you have to be very, very cautious. Before that, you should have a classical the recommended evaluation done by this particular the kidney function must be evaluated, the lipid profile must be evaluated, and a 12-lead resting electrocardiogram is very much required. Apart from the glycemic triad, the fasting and the post lunch and the HbA1c, all these are mandatory. And for type 1, I tell you, the moment the patient comes to you, you have to send the patient to an ophthalmologist to rule out the retinopathy. And in type 2, after 5 years, you can refer the patient to the ophthalmologist to rule out, because retinopathy is such a dreadful complication of this particular diabetes. Most of the times it is forgotten, and the evaluation is totally incomplete without the ruling out the presence or absence of retinopathy. Let it be whatever it may be, either macular edema or any degree of retinopathy must be ruled out. Then only it is 100% evaluation is completed. Or else, if you don't go for fundus examination, the evaluation remains incomplete. So, in that particular case, if the patient doesn't have macular edema, if the patient has macular edema, you are not supposed to put the patient on pioglitazone. It will be further deteriorated. The patient is got volume overloaded state. Maybe if you don't go for the renal function test, you don't see the creatinine, you don't calculate the estimated glomerular filtration, then how do you come to a conclusion that at what stage the patient is the DKD, that is diabetic kidney disease, 1, 2, 3, A, B, 4, 5. So you have to go methodically, go systematically. You take this thing, you go for a 2D echo also to rule out heart failure and all. So if the patient is doing extraordinarily fine, no other comorbidities, you can straight away go for a wonderful combination. The combinations are available in our country only, never in the US, never in the UK, never in the European continent. You don't get any combinations. We have got beautiful combinations. Even the combinations of the DPP4 with SGLT2 have come into vogue. The US FDA approved combination being the Boehringer product, the empagliflozin and the linagliptin, that is Glizambi, the 25/5 or the 10/5, it is available. I use it very extensively because these drugs, they bypass the pancreas. The metformin, DPP4 and alpha glucosidase inhibitors and the SGLT2 inhibitors, they bypass the pancreas. They have got only the extra pancreatic activities, and the remodeling of pancreas, that is preserving the beta cell, and reversal of this particular the diabetes is possible with this particular the SGLT2 inhibitors and this particular GLP-1 receptor agonists, and insulin to some extent that also works in the reversal of the diabetes. But the foundation is always the lifestyle modification and the therapeutic lifestyle changes. Unless the patient does some exercise, the Indian guidelines 60 minutes every day, 7 into 7, like okay, every day he has to go, and diet is very important, and weight reduction is very important. If at all is an alcoholic, he has to give up alcohol. No pointing in moderating the alcohol. Smoking should be stopped at once. These are all the 5 pillars, and all the time to be complete, you have to keep the checklist of ABC. A stands for A1C, B stands for blood pressure, C stands for this particular cholesterol, and the next thing is this microalbuminuria, that is the very very important, and the 5th marker is smoking. So you have to keep in mind all the 5 markers, the A1C and the blood pressure and the cholesterol and the microalbuminuria. Of course, the name is changed. The ADA has changed it to UCR, the urine UACR, that is urine albumin creatinine ratio, on the smoking. These 5 risk factors must be borne in mind. If at all you have to complete the case, the outcome must be good. The 5 factors must be addressed very meticulously.
Sir, he's asking one more.
Yeah. Wonderful that Pankaj is there. He's making the session very live.
He's asking that this analog insulins can cause any injection site reaction and cause any antibody formation. That's the last question, sir.
No, absolutely not. See, the antigenicity was high with bovine insulins, was little bit less with porcine insulins. Antigenicity was more or less zero with human insulins, and there is no antigenicity, no antibody formation with this analog insulins or designer insulins at all. What was the question? Second part was there. Satish, can you repeat the question?
Is there any problem at injection site? And the second
No. See, the local site reactions are common to one and all. Even it is the regular insulin, it is there if it is taken in a faulty technique. So we should teach the patient how to take the injection. First of all, the injection site should be abdomen, unless otherwise it is contraindicated. There are burns over the abdomen, so then forget about abdomen. Otherwise, abdomen is the best site for lifetime. Any insulin, let it be human insulin, let it be analog insulin, designer insulin, co-formulation, local site reactions are very common if it is not taken in a very proper way. That is, the patient should pinch the fat fold with the 2 fingers, and the patient, the technique should be taught to the patient very meticulously, leaving around 2 inches around the abdomen, the umbilicus, and it should be given with 90 degrees only, and you have to wait after the injecting, you have to wait for 30 seconds so that the medicine should go into the subcutaneous tissue. The site reactions occur commonly when the patient gives it intradermally. Beneath the skin they give, you see a bulge there. It is a wrong injection technique. See, if it goes into the subcutaneous tissue, because abdomen has got lot of abundant surface area of subcutaneous tissue, you can give it to that, and injection is very easy if it is given to abdomen, and the most important is it is not influenced by exercise. If you give it to hand or if you give it to thigh, if you walk or if you run, if you do some exercise, so that will be influenced and that will be absorbed fast, and if it gets into the muscle, deltoid muscle or in the thigh muscle, it will be the erratic hypoglycemia you may land up. But in the abdomen, you can never get into that because you have got abundant fat tissue. if the fat tissue is abundant, you have to adapt to the 90-degree technique. In type 1 cases or LADA cases where there is no subcutaneous fat, you have to adopt the 45-degree technique. So, and the greatest importance of abdomen is that it has got the venous drainage as well as the lymphatic drainage, so that the insulin you give will be utilized to the core. 100% insulin will be utilized. So these are all the greatest advantages, and you should teach the patient. Your staff must be well trained, because all my staff, they are well trained in giving the insulin. I don't teach the insulin at all. In my busy schedule, my staff are well trained in that. They at least one patient they take around 20 to 30 minutes, if at all in initiation of insulin is there. Any questions, Pankaj? Shoot me any question.
He's asking one more question.
Yeah, please.
He's asking one more question, sir.
Yeah, let
Can
him.
we add a glimepiride?
Pardon?
Can we add glimepiride 2 milligram with bias put twice daily?
Can we add glimepiride?
2 mg
Ah.
with bias, that is nothing but no mix
Twice
twice daily.
No mix twice daily. Certainly you can add, but without metformin, unless otherwise it is proven to be contraindicated, you cannot alone start the insulin aspart with secretagogue. I don't advise. This is an irrational combination actually, because once you start a secretagogue and once you give insulin, it's meaningless actually. Earlier we used to do that because we didn't have any options left over. We had only metformin, we had only this particular sulfonylureas, and off late in 1996 Bayer came out with the alpha glucosidase inhibitor, the acarbose, with the brand name of Glucobay. I still remember the day they have launched Glucobay in my own clinic. Many of the newer molecules are launched in my own clinic, my own chamber. So at that time we never had sufficient quantity or sufficient wide spectrum of drugs which were acting like DPP4 inhibitors, SGLT2 inhibitors, or the GLP1 receptor agonists, though injectables, whatever it may be. So we never had this much choice of insulin when I started my practice. So there was no human insulin at all available in my city or India at all. So it came later on in 93 or 94 to India. Before that we used to use bovine and porcine only. So there was antigenicity. What you said, antibodies, certainly it was there. It was an issue actually. But porcine was better than bovine and human was better than porcine, and the analogs and designers are better than the human, and the co-formulation like insulin rhizodec, insulin degludec aspart is superior to all. That's all. Sky is the limit for the insulin degludec and aspart. And one more molecule we are waiting for from the basket of Novo Nordisk, the icodec, the once a week, the basal insulin. It is under phase 3 or 4. I don't exactly remember. But once it comes out, it will be a boon for the patients, most of the patients. But I don't believe in combining this unless you add metformin to this sulfonylurea. If not 2 milligram, at least 1 milligram in the morning, 1 in the night, you can do that, but not the higher doses of secretagogues along with insulin. There is no point, because you are giving insulin at the same time your secretagogue will squeeze out insulin from the pancreas, so that doesn't catch up the story totally. So you give metformin and a low dose if it is required. You can go for even half milligram is available right now. And the Sun Pharma has got that half milligram, and even the USV has got that half milligram with metformin. So 0.5 milligram of metformin with 1000 or 500 milligram of metformin. Along with that you can go. Without metformin I would never recommend either any of insulins, either the human biphasic premixed insulin or the analog insulin, the Novomix or the Rhizodec, anything with this without metformin. Because you need a sensitizer, because insulin resistance is the culprit. At the same time, insulinopenia is the culprit in Indian subset. That is the biggest difference between the Pima Indians and the Asian Indians. That's what I said. The insulin resistance is the biggest factor for the risk factor for the pathogenesis of type 2 diabetes in Pima Indians, whereas we Indians face the insulin resistance as well as the lower fasting insulin levels, and even the after the 75 gram OGTT, the 30 minutes insulin is also 3 to 4 times lower than the other comparators. So we are badly running short of insulin. So it's a combination of IR plus IP, insulinopenia plus insulin resistance is the background pathology of our type 2 diabetes patients, Pankaj. So I think with that, any questions please?
Sir, Dr. Humayun is saying that excellent webinar. Thank you so much, madam and sir.
Yeah, thank you, Dr. Humayun. So kind of you.
That was the last comment, sir, in question and answer box.
Is my student Patwari happy? Patwari, I need your feedback on this.
Dr. Patwari sir, can you answer in question and answer session? Are you okay with all the answers by Dr. Saba as well?
Is a friend of mine on my WhatsApp, Pankaj Patwari.
Just a second, sir. I think one
Yeah.
more has.
Okay. He's an endocrinologist. Pankaj is an endocrinologist.
Okay. It's okay, sir. Closed, sir.
Session is closed,
Sir,
huh?
not responding.
No problem. No problem. If there is no question, we'll wait for 5 seconds or 10 seconds. We can wind up the session. If there are questions, I am glad to take any number of questions.
I did not see any question, sir.
No questions in the chat box?
No, sir.
Okay, I think it's... And
Call a day, sir, with your permission.
and I conclude by saying thanks to my dear participants and professional colleagues, and especially my thanks to Pankaj Patwari for making this session very live with his brilliant questions. And I once again thank Novonadis people for giving me the opportunity to be the speaker, and ma'am also is very happy to be the speaker of the evening, and we had a wonderful question and answer session. So I take leave of you. Stay safe. Don't worry about the COVID, but don't you use your mask, sanitize yourself, maintain social distance. Omicron is the end of Corona, I think, for rest of the world. Forget about the neo-cov and all. Nothing to worry about it. Nothing to worry about it, because the Omicron virus is the B.1.1.529 is a very less virulent virus that just comes like a flu and just goes with, just says hello, just says bye. That's all. Most of the patients they remain asymptomatic and don't need to worry about this. Don't use molnupiravir just like paracetamol. Don't make it another paracetamol, please. So stay safe and see you again in the next webinar. Thank you so much.